All right, Dr. Lieber, thank you so much for choosing to, interview with me, and as a part of the I Am an IMG event to speak to us a little bit, perhaps impart some wisdom on how a foreign medical graduate were to apply for the residency program here in the States. Is there anything that you'd like to just perhaps just mention, just briefly, about maybe the differences between an American medical graduate versus a foreign medical one, from your experience?
Sure. Remember that you can be a foreign medical graduate and you can have a green card in the United States or be a citizen of the United States. Today, instead of using the term foreign medical graduates, we use the term international medical graduates. I actually was a foreign medical graduate, you see, back in the late 70s, early 80s. And frankly, American medical graduates always are, quote, preferred. And the only reason I say that is I think the feeling in the medical field of the United States is they'll try to give the training programs to the students who are from states here and have trained here. However, the United States is a big place. We have a lot of areas that are underserved. One of the areas is the New York area. We sometimes call that the tri-state, meaning the tri-New York State area. So that's New York City, parts of New Jersey, which have a lot of hospitals. And many of their doctors are actually trained abroad. And in fact do very well here, very well. Parts of Chicago, which is is our third largest city in the U.S. That's in the Midwest. See? And there are other states that will look to get foreign trained doctors. Foreign trained doctors often bring a what's called world experience. Many of the American trained doctors, although they might be very bright and they know the system and they get through the system, they don't often have here it's called street smarts, meaning they don't often have the world experience. Whereas the doctor who trained abroad and had to come here and establish themselves are folks who are very, very capable of managing crises, so to speak, have had their own lives changed, and that's often a very nice thing to see in doctors. So what I'd always tell everybody is if you're going to apply here in the U.S., focus on the larger cities in the Northeast, such as New York, in the Midwest, such as Chicago. I think you'll find the West Coast, because frankly of the weather, often attracts American-born and American-trained. See? But there are a host of opportunities open for folks who've trained abroad. And I can tell you in our own program, most of our doctors are foreign trained. Some of them are citizens, but we have many who trained in all different countries. See, there are also many hospitals that will sponsor visas because there are some superb candidates out there, I can tell you right now, who have a visa need. And hospitals are perfectly willing to work with them, including even large hospitals. So Mount Sinai does sponsor visas for certain individuals.
So would you suggest basically that people should probably be doing their research, as in perhaps avoid the hospitals in which they say, we do not actually sponsor the visa. Simply,
yes.
Okay.
Yes.
Okay.
I mean, unless a visa issue, again, unless a visa is not an issue, but in many cases it is. If they're not going to sponsor, focus elsewhere. See, a perfect example, we have a lot of students here from Canada. Now, interestingly, the Canadians need visas when they come down here. So we have students who go to some of our foreign schools who are, whose background is Canada. And yet, even though Canada is our northern neighbor, it could be hard for many of them to get a visa here.
Oh, wow, okay.
See, and that's our northern neighbor, you know what I'm
Yes,
saying?
of course.
So that's almost a little sad, because you would think that that's a country that we have a lot in common with, but next to.
Mm-hmm.
You know, individuals go back and forth all the time. But there are a lot of programs that will sponsor visas. And what I would always say to you is focus on the areas where you get that. Again, the northeastern U.S., especially around, you know, New York, Hartford, Connecticut, would be very good. Sometimes even upstate. Now, you know, New York is a state. Our city is downtown, but upstate New York, Albany, Buffalo, are big cities, and frankly, it's a little colder up there. They have some very big medical centers that may not be the first choice for some of the American graduates, but let me tell you something, you get a fantastic education up there, fantastic. And you can really do very nicely up there, you see? So even look there, in other words, be a little more kind of creative in what's up there.
Mm-hmm.
Because there are a lot of programs that are just dying for good, you know, trained doctors.
Okay. So, I mean, obviously, we all know as medical students that part one, part two, like these are the major factors
Right.
that obviously play in. But being that the students already know that, I was wondering if you could maybe shed light on some of the X factors
Okay.
that perhaps foreign medical grads may be able to take advantage of, you know, before they apply. Because usually when they're applying, they do not have the U.S. experience before they apply. Many of them may not.
Right.
So,
You
is
know,
there
that-
anything?
That doesn't necessarily hold against them. What I would always say to you is, if you have taken time off, utilize that time for something. So, in other words, many people, many trainees might, you know, be waiting to come here. Try to do observerships, try to work in a lab. Keep yourself active. See, that's the major thing. In the United States, there's often this concept that somebody who's been out of training for 5 years is a less valuable candidate because
Mhm.
they've been, you know, out of their training. So if you graduated medical school in 2005, let's say, and it's now 2011, and you haven't done anything, you're not going to have as good a chance. But if you have, we have many people who we interview here who graduated 2-3 years ago, but have gotten a master's of public health, have done, you know, research in a lab and gotten things published.
Mm-hmm.
See, and that really helps you because you have remained active. I think that's very important. Having you know U.S. experience is nice, but is not a must.
Okay.
It's not a must because we all know once you get here, we'll train you. You see?
Of course.
It may be a little easier to know some of our terms and systems, but everybody's smart out there. You know, they can adapt quickly. See?
So you're saying it's not necessarily a like requirement on like, you know, the application, you know, must have had so and so many
Not at
months
all.
of
Not
okay.
at all.
Okay.
In fact, I know some programs, frankly, that would easily take somebody who worked at Aga Khan University, for example,
Mm-hmm.
in Pakistan, or
Mm-hmm.
All India,
Okay.
and work there and really work. You know, both these are great places, and say, you know what, these are people who could easily come here and function. So no, it's not a must, not at all.
Okay, okay. And you're speaking obviously about these major cities that are
Yes.
serving the underserved and
Yes.
so on. Okay, okay. So I wanted to speak also about what is the patient load like in a typical inner city hospital?
Okay, it's generally heavier, and the reason is unfortunately in the United States, patients often utilize hospitals for primary care. We still don't have, despite you know our you know costly healthcare system, we don't always have a lot of good outpatient management.
Mm-hmm.
So you're probably going to be taken care of, not alone, often with a resident, about 10 patients per intern.
I see.
You know, some of those patients may have minor things, others may have more complicated fevers of unknown origin. because we have a lot of travelers, meaning individuals who come, from abroad here, they might bring their kind of illnesses with them.
Mm-hmm.
So we have patients who come off the plane here with MRIs of lesions,
Okay.
and they're coming here to have it evaluated.
Mm-hmm.
See? And remember, one thing here in the U.S., if a patient comes to an emergency room and is sick, they have to be admitted and have to be taken care of.
Mm-hmm.
So the volume is fairly heavy, but it is regulated. There is a board called the ACGME, and they regulate how many patients a resident is taken care of, because they don't want it to be overly excessive. That leads to, of course, bad care. And remember, the point of the trainee is they're learning.
Right.
And if they're taking care of too many patients, they're not learning.
Mm-hmm. Mm-hmm.
See? So that's very important, and that is watched by all training programs. If we see that our house staff are taking care of too many patients, we have to modify that. And we have ways of taking care of that. We have what's called non-teaching services, for example. Those are services that are not run by house staff, they're run by what are called mid-level folks, such as nurse practitioners, nurse midwives, and they handle those patients with a supervising attending, so the residents are never involved with those cases.
Mm-hmm.
See? So we have a lot of ways. It's a heavy load. It's not smoldering. It's not crushing.
Mm-hmm.
It's heavy. Many of the patients, especially in larger cities, do have, aside from medical issues, psychosocial issues.
Okay.
And that often takes a little time. So again, in a city as big as New York or Chicago, many patients are going to need social management as well. You see, and that will be part of the team's work. That's not all going to fall on the doctor. The doctor's going to have social workers to help them, etc. So, so the doctor's not going to talk to the patient about what your bill is going to cost, this or this. That's taken out of the doctor's hands.
Mm-hmm.
But that is a factor that the team, including the doctor, the social worker, the case manager, all that team will kind of work with that. See?
Mm-hmm.
And we're also very careful about having good supervision. So we don't want everything to fall on the trainee, on the internal resident. So if they have questions, they have people they can go to.
Mm-hmm. So the hierarchy is well established.
It's well established.
Okay.
I think you'll find that depending on the hospital, it can be looser in the sense that, in our hospital, PGY1s, talk to attendings, no problem. Whereas in other hospitals, it's the PGY1 goes to the PGY2, and it works its way up the ladder.
Got it. Okay.
I think you'll find in many of the underserved institutions, and I will use ours as a perfect example, we have no problem having a PGY1 talking directly to an attending, whatever, and vice versa.
Mm-hmm.
So there is a hierarchy more for just general care and management, but it's never an absolute, kind of military hierarchy.
Okay. Well, obviously, internal medicine is probably one of the highest in demand for a foreign medical graduate, and being that obviously you've had many years of experience not only hiring me, but working with them, can you just shed some light, perhaps, on how the department works, how you see the foreign medical graduates interacting, how they adjust, things of that nature?
Yeah. Fortunately, we have a lot of internal medicine programs,
Mm-hmm.
and that does balance out the fact that a lot of people want to go into it. I think the international medical graduates feel a tremendous need in this country, and I think everybody understands that and recognizes that. So I'm happy to say that a good number of IMGs get their spots and actually move on afterwards. I think they adapt very well, because many places that they tend to go tend to be culturally diverse. So if you think about it, again, a large city like New York, Chicago, is accepting of all different backgrounds, you see, and kind of welcomes that. So I have to say, from the residents I've seen who've trained abroad, and even from those who lived abroad, adapting here is easier than it sounds. You see, the culture is very diverse. Everybody's kind of accepted. As long as people do their job, which they do, and want to learn, they're going to go ahead.
That's fantastic.
You see, which is very nice. It's very nice, and that's especially true in the larger cities. I will tell you that there are more rural programs in the U.S. where IMGs may go to also. And the reason the rural programs have a certain number of IMGs is many smaller cities don't attract the American graduate. And one reason is the American graduate wants to live perhaps in the big city, in the hustle and bustle, and doesn't want to be in a small town of 4,000 people. See? But the IMGs often fit in nicely there. Those areas can be a little more kind of homogeneous. And yet I will tell you now, and I know a lot of my colleagues have gone to towns like that. They're very accepting of anybody who's a physician there. So I know trainees from all different countries who've gone even to small rural towns in the southern United States, and they're loved by the people. They're loved because they view this individual as helping them. You see, so I think there are a lot of ways to approach this. There are a lot of programs out there. I think if somebody comes in and is bright and is caring, the population sees that.
That's great.
Which is very nice, yeah.
Obviously, it's been wonderful to hear the information about the residency itself, but a lot of the students, of course, want to know, what does a typical CV of a candidate look like for a medical grad who gets called in for an interview and then gets accepted into your program?
Okay. Generally, the quote preferred, quote, is somebody who has not been out of training for more than 5 years. And if they are, they've had that 5 years taken by doing things. See, we need something that's hard and fast. And one thing that's hard and fast is an exam score.
Of course.
And often, the step 1 and step 2, I would say step 2 CK may even be more important.
Really?
Yeah. I'll tell you why. Because, see, American grads take step 1, take step 2 CK late.
Okay.
Later. The IMGs take this step 1 and need step 2 CK because many programs focus on that.
I see.
It's almost a cutoff. That's not to say step 1 is not important. But if you do okay on step 1 and do stellar on step 2 CK, the program is going to look at you. See? They're going to say, this is somebody who has a good fund of knowledge, understands our system, has been out of training for 2 years. We'd like to interview them. Another reason the steps become important is one way that residency programs are judged in the United States is their what's called board pass rate.
Okay.
So if I'm running an internal medicine program and I have 16 graduating residents and half them fail the internal medicine board exam, the program is going to be in jeopardy.
Okay.
And it's often felt that these steps give you an idea of how people are going to do on the internal medicine board.
Okay.
Not everybody believes that, but it's one thing you can use as a as a guide, as a guidepost. See? So try to do well in your step 1 and step 2. Step 3 is not mandatory in order to get into a program. Okay, step 3 will be mandatory when you're in the program in order to get licensed. But if you have time off and you think you can do well in step 3, and there are many people who can because they've training and active, take it. But don't take it unless you're sure that you can do it. See, it's important not to take an exam unless you're pretty sure you're ready.
Mm-hmm.
I think individuals who have U.S. experience are not necessarily at a major advantage depending on the program. Because
Okay.
there are programs, as I just told you, that will take somebody who's trained in a large center in another country, yet has done well in their steps, has graduated within 5 years, obviously is bright, and they bring a lot of cultural experience in, which is very important here.
Mm-hmm.
See, our country is a very, very culturally diverse place, and bringing a little bit of cultural understanding is critical. Other languages, we have translator systems, but it's very nice to have somebody who speaks multiple languages. And there are many, kind of in demand. So many things are looked at.
Is that advantageous? The obviously being bilingual, multilingual, that type of thing. Because obviously there is a translator system,
Mm-hmm.
but I mean, even as I have worked in an observership a bit for about a month, and I have noticed that many times because of the high demand, translator might be unavailable. There might be maybe like a lack of doctor-patient
Yeah.
repertoire almost, simply because the translator's kind of the
Absolutely.
in between.
Absolutely.
So that is an advantage, yes. To
I think there's an unwritten advantage.
okay.
I think nobody will necessarily say, because you speak 4 languages, it'll take you, but I'm
Mhm.
going to tell you right now, I'm very happy, and I welcome a new trainee who's multilingual and knows how to talk to patients, because it's that doctor-patient interaction that we sometimes lose when we're busy.
Mm-hmm.
So it certainly is something to play up, recognize. Look, I can speak 4 languages or 3 languages. I feel very comfortable talking to patients in all these languages. Believe it or not, although it won't be a written thing, it's in the back of the mind of people.
Mm-hmm. Could it perhaps, since it's in the back of the mind of someone, this cultural diversity, language that a foreign medical graduate may have, could maybe put them above, let's say, another candidate that perhaps, maybe only has English as their proficient language, and somebody who perhaps is lived in the tri-state area their entire life.
It could.
Yeah.
And again, I can tell you, especially in a larger city where you're going to have multi-cultural, getting somebody who can speak multiple languages, who's comfortable with all different types of patients, that's, again, an unwritten thing in your favor.
Mm-hmm.
So when the rank list finally comes out, if the two have a similar score in the Step 2 CK and similar training, and yet somebody's multilingual and somebody has done work in a large hospital abroad, and has good letters of recommendation, which is very important also, that's quite important. What I would say about the letters of recommendation, if you're going to get a letter of recommendation, get it from somebody with a standing in the foreign university.
Meaning?
Somebody who's a professor, a lecturer, rather than a local doctor. That's not to say the local doctor's not good.
Mm-hmm.
It's just that often the letter reader won't know who that local doctor is. And that could be a family friend.
I see. Okay.
See?
Okay.
But again, if somebody trained in a large hospital, for example, in London, even though I don't know all those people necessarily, if I get something from a professor in London, I'm going to give that weight.
Right.
Same thing, at the University of Cairo, I'm going to give that weight.
Mm-hmm.
That's somebody who has standing in that university.
How about a head of department, for
Also,
example?
Very
Yes.
same thing. Yes.
Okay.
Yes.
Okay.
Yes. Absolutely.
Okay. Is there any other advice that perhaps you may want to give, let's say somebody applying the next 1 or 2 years into the internal medicine department?
What I would say is the first thing is just get those steps over with.
Mhm.
Stay in medicine, be it research, be it observership, studying for step 3 if you want to, and get an idea of where you want to focus your applications. So you might want to find out, if you're coming from a certain school or country, where have your graduates gotten in before?
Mhm.
So if there are hospitals in Chicago or hospitals in Cleveland that have taken your graduates before, they might be very happy with that.
Let's say there haven't been.